What are they and what do they mean? Join me in welcoming Dr. Melanie Gillingham. Her research in the Department of Molecular and Medical Genetics has focused on various novel therapies for fatty acid oxidation disorders. For 20 years, Dr. Gillingham and her colleagues have conducted clinical trials in subjects with disorders in the fatty acid oxidation pathway. She has examined the effects of medium chain triglyceride supplements prior to exercise on exercise performance among subjects with long-chain dehydrogenase deficiencies, receiving the Emanuel Shapiro Award for Best Paper in Molecular Genetics and Metabolism. The Gillingham lab has evaluated the effects of increased dietary protein on metabolic control and energy balance in subjects with LCHAD, carnitine, CP2, and very long-chain VLCAD deficiencies. In a separate study, Dr. Gillingham conducted supervised metabolic fasting studies in young children with a polymorphism of the CPT1A gene to determine if they have an altered fasting response similar to other fatty acid oxidation disorders. In 2012, a group of FAO researchers under the leadership of Dr. Jerry Vockley founded the Inform Network for Fatty Acid Oxidation Research and Management, an international group working for the advancement of medical nutrition therapies for fatty acid oxidation disorders. The Inform continues to host annual science meetings and work on clinical trials and funding for projects within the group's members. Most recently, Drs. Vockley and Gillingham completed a randomized trial to examine the effects of an odd-chain fatty acid supplement, triheptanoin, on myopathy and cardiac function of patients with long-chain fatty acid oxidation disorders. This is the largest randomized controlled trial conducted in these disorders to date and was recently selected for the Garrett Award by the Society of the Study of Inborn Errors of Metabolism. Dr. Gillingham has also conducted a series of studies examining the etiology of retinopathy in LCHAD and the role of diet in progression of vision loss. Dr. Gillingham has recently been awarded an NIH grant to conduct a larger natural history study of LCHAD retinopathy with a goal of recruiting 44 subjects over the next 2 to 4 years from the Inform Network. And so I also just recently learned before we came on that Dr. Gillingham has published a cookbook with recipes to cook with MTC oil. And so we'll be providing information on that. It is available on the OSU Tech website, and we will make that available on the MitoAction website and also to all of our participants in the conference. So please join me in welcoming Dr. Gillingham.
Thank you, Kara. That was a very nice introduction. This meeting has been a lot of fun. I've enjoyed listening to the other sessions, and so I appreciate being invited to share. So I'm going to spend some time talking about acylcarnitines. And I suspect this is a biochemical blood test that you have all heard your physician talk about over the course of your experiences with fatty acid oxidation disorders. It's the primary biomarker that we use for diagnosing, and Dr. Arnold talked a bit about it in her newborn screening talk this morning. About 1.5 years ago, I was fortunate to work on the VLCAD nutrition guidelines, which you're going to hear a little bit about from my friends Mary and Dr. Sandy Van Kalkar in a few hours. And we had a nominal group meeting, and we had some pretty detailed discussions about acylcarnitines. What do they mean? What makes them go up? What makes them go down? And for the past 1.5 years, I've really been sort of geeking out about acylcarnitines, thinking about the physiology of these biomarkers, both in normal physiology, but particularly as they pertain to fatty acid oxidation disorders. So I'm going to try to share a little bit of how I've been thinking about these molecules and some of the ways I've been trying to look at data to see if we can shed some light on how acylcarnitines change. So I'm going to try to advance my slides. It doesn't seem to be advancing. Is there a trick, Jeff, that I may do to make this go forward?
Look on the very bottom left. There's an arrow.
There's an arrow.
Bottom left.
Let's see. Remote control.
Try just hitting your right arrow key as well.
Okay, tried that. Doesn't seem to be going forward. Let's see. So it's,
do you see? There you go.
do I see these down here?
No,
It says
it
annotate,
advanced.
hit advance.
I see acylcarnitine. I see a different slide there.
Oh, there we go. Okay, I did something. I don't know what. All right, so these are the questions I'm going to try to answer. Sorry about that. Acylcarnitines, what are they? And a related question is, what is carnitine? How are they made? Why do we care about them in fatty acid oxidation disorders? And then I'm going to spend quite a bit of time focusing on how do they change throughout the day? What makes them go up? What makes them go down? And ultimately, the question we want to ask is, do they have any relevance on health outcomes? What do they mean? I am going to figure out how to.
If you take
there
your,
it goes.
there you go.
It seems to be going slow. Okay, so let's talk about what are acylcarnitines. The best analogy I could come up with is that they're a carrier molecule that basically delivers fatty acids into the mitochondria. So if you think of fat, when you're making an oil and vinegar dressing, you know that it doesn't mix well in a water environment. So in our bloodstream, which is a water-based environment, fats circulate in these large protein, cholesterol, fat balls, lipoproteins. And you might be familiar with lipoproteins if you've had your cholesterol measured. So LDL is a type of cholesterol that we measure, and it carries fat throughout the circulation, and those fatty acids get taken up into cells. However, those fatty acids cannot get into the mitochondria where fatty acid oxidation occurs. And so to do that, we bind the fatty acid to a carnitine molecule, and that is carried into the mitochondria. So like a mailman delivers your mail, the carnitine's sort of delivering the fatty acid into the mitochondria. So this is a picture of the carnitine transport shuttle that we've seen a couple times over the course of the meeting. We get a fatty acid that comes bound to coenzyme A on the outside of the mitochondria, but it can't get in. So CPT1 takes the CoA off and adds a carnitine molecule to form a fatty acylcarnitine. So the fat molecule on the carnitine could be a number of different types of fatty acids. It could have 16 carbons or 18 carbons. They're usually long chain fats that are attached to this carnitine. Then the carnitine translocase, the CACT enzyme, moves that acylcarnitine into the mitochondria. And at the same time, it pumps free carnitine back out into the cell so that it can be used again to move more fat into the mitochondria. Once the fatty acylcarnitine is inside the cell, CPT2 takes the carnitine back off and adds the CoA, and that's when fatty acid oxidation begins. So this acylcarnitine should technically be predominantly inside cells in the mitochondria. So where do we get carnitine, and what is carnitine? Carnitine, the carrier molecule, is actually a compound synthesized from the building blocks of protein, amino acids. So in our liver, we can take two amino acids, lysine and methionine, and make carnitine. We also eat carnitine in foods. Carn is from the Latin root that we get carnivore. So you can think of carnitine being predominantly in meat. There is some carnitine in other foods, but the majority of the carnitine that we consume in our diet typically comes from meat products. As I was kind of thinking about carnitine, I did a little bit of research on how much carnitine is in a typical diet, and it's interesting. Vegetarians who don't eat meat do have lower circulating free carnitine than carnivores. It doesn't get real low, but they do have lower circulating carnitine. So meat is a source. That's interesting to me because if you have a long chain fatty acid oxidation disorder and you're following a very low fat diet, meat tends to be one of those high fat foods that you might eat less of, and therefore might be consuming a little bit less carnitine in your diet. Sometimes carnitine gets low in patients with fatty acid oxidation disorders. Part of that is because when it's bound to the acylcarnitine, it can spill into urine, and you might lose a lot of carnitine in urine that someone who doesn't have an FAO disorder would not lose. And your liver just can't keep up with making enough carnitine to keep your blood levels in the normal range. So sometimes you might be prescribed carnitine supplements. So another way we could get carnitine is to take supplements. And I bet you many of you on this session are very familiar with those types of carnitine supplements. So where is the carnitine, the carrier molecule in our bodies? There is a little bit in blood, and that's what we measure, but most of our carnitine is actually in tissues. And it prefers to be in tissues that use fat for energy, which makes sense. So there's fairly high concentrations of carnitine in skeletal muscle, in the liver, in the kidney, and in the heart. We do have some carnitine that circulates in blood. That's a free carnitine. If we have a carnitine profile, you usually get a number that's a free carnitine, and then how much is bound, or acylcarnitines. And we want our free carnitine, typically normal is between 30 and 50, can go as high as 70, but we don't want to get it too low because we need the carnitine to be the carrier molecule. And in patients with fatty acid oxidation disorders, as I mentioned, some of the acylcarnitines that are bound in the fats, especially the shorter chain fatty acids, can spill into urine, and you can lose a lot of carnitine that way. And your liver has to make more, or we need to add a supplement to get that free carnitine back up into what is considered normal range. So in a system where fatty acid oxidation works, carnitine makes an acylcarnitine bound to a fatty acid. It comes into the mitochondria. CPT2 converts that back to a fatty acyl-CoA, and it undergoes fat oxidation using all of the enzymes that you are all very familiar with. So VLCAD, trifunctional protein, which includes LCHAD, and they chain shorten the fatty acid, releasing acetyl-CoA, MCAD, the short chain system. They take the fatty acid and they basically convert it to energy, ATP, CO2 that we breathe out, and water. And free carnitine is in the cell. So for a fatty acid oxidation pathway, typically we don't see a lot of free acylcarnitines in blood. They are typically extremely low because the fats are being converted to CO2 and water in the mitochondria, and you don't get this increase in acylcarnitines in the blood system. But if you have a fatty acid oxidation disorder, I'm going to focus here on CPT2, VLCAD, and LCHAD, or trifunctional protein, but it would be true with MCAD or other disorders in the pathway as well. The acylcarnitine, the fatty acid in the mitochondria doesn't get fully oxidized. You might have some partial oxidation for what residual enzyme you might have, or it might just build up the long chain fat that cannot be oxidized because of the block in the pathway. So this fatty acid that builds up inside the mitochondria actually gets reattached to carnitine, and then it comes back out of the cell through that same translocase transporter, and it shows up in blood. So a block in the pathway with incomplete fat oxidation, we start seeing the rise in these acylcarnitines in blood. And that's what we use to, as a biomarker, to look at how much fat, partial fat oxidation has been happening, and we see these go up in patients with fatty acid oxidation disorders. So we capitalize on this to do newborn screening, as Dr. Arnold talked about this morning. So we take a blood spot and we measure the acylcarnitines in that blood spot. And there's a very particular pattern that shows up depending on what fatty acid oxidation disorder might be present. This pattern is showing a profile for a TFP deficiency. So you'll see increases in, at the long chain, like 16 and 18 species. And when this acylcarnitine is positive, it triggers the blood spot to be flagged as a potential fatty acid oxidation disorder. And as Dr. Arnold mentioned, there's follow-up testing and further tests to confirm the diagnosis. But we use this acylcarnitine profile in newborn screening all the time, and it's been amazing that we can pick up babies so early in life. It's been a really wonderful advancement. But what about after diagnosis? You've been diagnosed with a fatty acid oxidation disorder. How useful are acylcarnitine measures after you have been diagnosed with, say, VLCAD or LCHAD? Some of you, when you go visit your biochemical geneticist or one of your other physicians, they might order routine plasma acylcarnitines to measure what acylcarnitines are in your blood on any one given day. For sure, if you go into a metabolic decompensation or crisis and you get admitted to the hospital, most likely they're drawing blood and measuring acylcarnitines during crises. So that was part of our debate as we were developing the guidelines. How useful are those acylcarnitines? What do they tell us if we draw them at a routine physical visit with someone who we know has a fatty acid oxidation disorder? We know that if you get sick, you have a metabolic decompensation, rhabdomyolysis, the acylcarnitines go very high. You can see a big increase during crises. But how do they change if you're feeling well and eating and healthy at home? What makes them go up? What makes them go down? So a part of this debate, I started thinking, what data do I have that I could look at this and try to describe what happens to the acylcarnitines throughout the day? So what I decided to do and what we've done is we've taken some data from the randomized trial that we did with triheptanoin and C8. And we took those blood samples and we looked to see what happened with the acylcarnitines throughout the day. Some of you on the call may have participated in that study, so this diagram might seem familiar to you. The patients that were in the study flew to either Pittsburgh or OHSU, and they were admitted to our clinical research center. And we fed them a diet that was about 20% of their energy from MCT, a little bit of long chain, a lot of complex carbohydrates and some protein. And we fed them this diet from our kitchen for 2 days. On the first day, there were some other tests like echocardiograms and MRS. And on the second day, we drew some blood samples. So after an overnight fast of about 10 hours, we placed an IV in the subject's arm and we drew a blood sample before breakfast. We then fed everyone a controlled breakfast with a known macronutrient content. 2 hours later, we got another blood sample. 2 hours after that, we got a sample again, 4 hours after breakfast, and then they ate lunch. About 2 hours after lunch, we'd get started set up for a treadmill test where we would walk on a treadmill for about 45 minutes, and they would take some MCT before they got on the treadmill. And we got a blood sample right before the treadmill, and then again after the 45 minutes of exercise. So we have blood samples fasting, after breakfast, right before lunch, and then before and after the treadmill. And then the following day they went home, and a couple things I'll point out about the data I'm going to show you is that this was all done, all the samples I'm going to show you are from the baseline visit. So we had everyone come in at baseline before they were randomized to either C7 or C8. So this is, everybody's on commercial MCT at this point. We haven't looked at the data after randomization to date. So that data hasn't really been studied so far. So what happens to the acylcarnitines in these blood samples? I want to start with CPT2 deficiency. So this was 10 subjects with CPT2 deficiency who were in the study. And the graph on the left shows the fasting acylcarnitine species. The numbers on the x-axis are the fat that's attached to carnitine. So C16 would be 16 carbon fatty acid. The colon 0 means there's no double bonds. So it's a saturated fat that you might find in chicken or fish, and it's attached to carnitine. C18 would be 18 carbons. The colon number 1 is one double bond. So C18-1 is a fat that's found in olive oil, for instance. It's the main fatty acid in olive oil. The pink shaded area in all of these graphs is the normal range, which you would expect to be normal in someone's blood after an overnight fast. And you can see that patients with CPT2 deficiency, even though they're eating at what we consider sort of an ideal diet, their acylcarnitines are still elevated above normal range. And the highest one is the C18-1 acylcarnitine species, but all of them tend to be a little high. C12 is pretty normal. C14, a lot of them are in the normal range, but the C18-1 is definitely elevated. On the right-hand side, you can see how the 18-1 acylcarnitine changes throughout that whole day of drawing blood. So at fasting, they're the highest. These are the means, or the average of all of the 10 patients. And then the little whiskers are the variation, or how much variability is in that data. Everybody was fed this nice breakfast, and you see this drop. So eating actually caused about a 60% drop in the C18-1 acylcarnitine. All the acylcarnitines went down. They stayed relatively low. They ate lunch. They're relatively low before the exercise. And then you see this big jump up after a 45-minute moderate intensity exercise. So there was an exercise increase to the acylcarnitines. One thing I will point out is that the whiskers, the variability is really broad. So the response was very different among patients with CPT2. Some patients had a huge jump in acylcarnitines with exercise. Others had a more moderate response to exercise. In general, exercise made it go up, but the variation was larger after exercise than with an overnight fast. So there seems to be this natural variability throughout the day where their acylcarnitines are higher with fasting. If you eat, the acylcarnitines go down, and if you exercise, the acylcarnitines go up again. So let's look at the same data with VLCAD deficiency. So this was 8 patients with VLCAD deficiency. And again, we have on the left the fasting acylcarnitine species and how they might vary across these patients. And you can again see that the C14-1 is acylcarnitine, so the fatty acid that's 14 carbons with one double bond, that's the highest in VLCAD deficiency. We see that in newborns as well. The C14-1 seems to be highest for VLCAD. And there seems to be some variability from patients. Some patients have really high levels and others have maybe a little bit lower. If you look again on the right, we can see how it changed throughout the day. So this is C14-1. And again, at fasting, it was high after an overnight of not eating. We fed breakfast to everyone, and we saw this 60% drop in the acylcarnitine species. So after a meal, the acylcarnitines went way down. They ate lunch, and then 2 hours later, we did the exercise. And again, we saw this rise with exercise, high variability. Some people had quite a bit of rise and others not so much, but there seems to be this pattern of high acylcarnitine with fasting, decline with eating, and then rise again with exercise. So the last group I'll show you is the patients with LCHAD and trifunctional protein deficiency. So this is 11 patients with LCHAD and trifunctional protein deficiency. And again, you can see the species are specific to the disorder. So in these disorders, we see elevations in the hydroxy species. So the 18 carbon with one double bond hydroxy, C18-1 hydroxy, was the highest in this group of acylcarnitines that I'm showing here. And again, you see the pink is the normal shading. So they're quite elevated. There's again, a lot of variability. Some patients have really high acylcarnitines, others have lower. Again, if you look on the right, you can see the change throughout the day. So the C18-1 hydroxy was highest with fasting. We fed a controlled breakfast, and again, we see about a 60% drop 2 hours after breakfast. So it decreases. It doesn't get down to normal, but it gets lower. And it stays low. Really interestingly, we didn't see much of a change with exercise in the hydroxy acylcarnitine species. It stayed pretty much the same after exercise in the patients with LCHAD and trifunctional protein deficiency. And that's different than what we saw, which I just showed you in CPT2 and VLCAD. There was not as much of a response with exercise. So what factors are controlling this change in acylcarnitines throughout the day? One factor that I want to mention is genetics. So your particular mutation changes the enzyme uniquely for that mutation. So some mutations might be more severe. Dr. Bockley mentioned that in his talk earlier today, and really decrease the function of the enzyme. Some mutations might be milder, and you might still have some residual enzyme function and protein folding. So I think mutations play a big role, and this is something that you don't control. It's just part of the genetics of the disease. To illustrate that, I'm showing here, this is C16 hydroxy in our 11 patients with LCHAD and TFP. In the red is the 2 patients with a trifunctional protein that were in the study, and everyone else either had 1 copy or 2 copies of a common mutation for LCHAD, the G1528C. And you can see that the trifunctional protein deficient, those 2 patients had much lower hydroxyacylcarnitines, and I've seen that pretty consistently. And if you do have a copy of the common mutation, your hydroxyacylcarnitines are higher. So genetics plays a big role in how high the acylcarnitines are going to go, and how you might respond to fasting and exercise, because it's the protein, the effects of the genetic mutation on the protein that drives part of what we're seeing in these changes in acylcarnitines. What other factors might control these changes? We mentioned in the beginning that fat doesn't mix well with blood, and it circulates bound to protein. After a meal, it's bound in those lipoproteins, those things that we measure for cholesterol, like LDL. But with fasting, we actually release fatty acids from our adipose tissue, and they circulate loosely bound to blood proteins, and we call those free fatty acids. So those free fatty acids are endogenous. That's not from your diet. It's endogenous fat stores that we're releasing into the bloodstream to be used by various tissues for energy, for fatty acid oxidation. So I wondered if the free fatty acids would be related to the acylcarnitines. So to look at that, we took those same blood samples and we measured the free fatty acid in those blood samples. And here I'm showing you all 30 patients that were in the study. And we measured the free fatty acids again after an overnight fast. We fed them breakfast, 2 hours after breakfast, right before lunch, 4 hours after breakfast, and then before and after exercise. The time scale is on the x-axis and the free fatty acids are on the y. You can see CPT2, the group is in the dark circles. We have open squares for VLCAD and then some gray triangles for the subjects with LCHAD. And similar to what I showed for the acylcarnitines, you see that free fatty acids are high after sleeping through the night, after an overnight fast. When you eat breakfast, you see this drop, a little bit of a rise before lunch, and then you eat again and they drop, and then again this rise with exercise. So the free fatty acid pattern of high with fasting and rising with exercise is consistent with what we saw in the acylcarnitines. So on the right-hand side, I've taken the acylcarnitines for everyone and summed them all up to come up with one number so that we could compare all 3 diagnoses on one graph and look at one number that's comparable. And we see a similar pattern. So after fasting, we have this rise in acylcarnitines with all of the diagnoses. You eat, you see about a 60% drop, and then again they go up with exercise. But you can see in this graph that again the exercise rise is more dramatic in CPT2 and VLCAD than it is in the patients with LCHAD. So it seems that free fatty acids follow a similar pattern as the acylcarnitines. So perhaps it's the release of the free fatty acids from adipose tissue that's driving the partial fat oxidation and the appearance of acylcarnitines in blood. So let's spend a little time just thinking about the general physiology of fat oxidation during fasting and during exercise. So after we've slept overnight, we start off using glucose, and as the glucose declines, we start releasing fatty acids from our adipose cells, our tissue, our fat tissue, and those free fatty acids travel in the circulation to the liver. And the liver uses those fatty acids to make ketones through fatty acid oxidation. So the liver increases its fat oxidation during fasting to spare glucose and make ketones as an alternative fuel source. Muscles during sleep or fasting have a very low energy requirement, so they're not using a lot of energy at all, and they aren't doing a lot of fat oxidation. They tend to be asleep and not demanding high energy. The liver, however, is doing a lot of fat oxidation. So one of the things we know is that high free fatty acids in fasting drives fat oxidation in the liver. So if we release free fatty acids from adipose, it's directly correlated with the amount of fat we're burning in our liver to make ketones. So these rise in free fatty acids is pushing the liver to burn the fat to make ketones. And in the case of a fatty acid oxidation disorder, we see the rise in acylcarnitines from the liver partially oxidizing the fat and unable to fully oxidize that fat. And we see those acylcarnitines come out in the bloodstream. So one of the things that made me realize is that in fasting, the source of the acylcarnitines that we see in blood is most likely the liver. We would need to do some more studies to 100% prove that, but it seems consistent with what we know about general physiology, that the source in fasting is really the liver burning, partially oxidizing fat and making acylcarnitines and putting them into the bloodstream. So what about exercise? Exercise is a different beast. It's a little different story. So when we do exercise, our skeletal muscle now has a high demand for energy, for that ATP that Dr. Bockley talked about. We need more energy to run, to lift weights, to do whatever activity we're doing. But the sources of that energy are much more varied during exercise. So inside muscle, we store some carbohydrate as glycogen, and we store some fat as fat droplets. So the muscle has some internal energy stores that it can use. So it can mobilize the fatty acids and the glucose stored in the muscle cell directly. The muscle can also take up energy substrates from circulation. So as we exercise, we do start releasing fatty acids from our adipose tissue, just like fasting. And those fatty acids enter the bloodstream and travel in the circulation to the muscle, so the muscle can take up those fatty acids and use it for energy. And the liver can also take up those fatty acids and again do fat oxidation and make ketones, which would be another source of energy for the muscle. So during exercise, instead of it just being predominantly fatty acids released from adipose, we have a lot of different energy sources that are coming from a lot of different places. So perhaps that's why the difference after exercise is a little more complicated. The acylcarnitines are now probably being made in multiple muscle groups throughout the body. And the source of that fat that it might be partially oxidizing, and that's why we're seeing this rise in acylcarnitines, could be the fats found in the muscle. It could be the fat mobilized from adipose. It could be coming from a couple of different sources. So certainly exercise is a bit more complicated. And what do we know from general physiology that drives fat oxidation during exercise? There's a couple of things that are important. One is the intensity of exercise. That's the main thing. So if you think of a sprinter who sprints as hard and fast as they can, that is really glucose. You can't use fat that fast. So a sprinter is really relying on glucose stores, and it's a glucose type of exercise. Moderate exercise, think of a marathon runner or walking at a moderate pace where you can still have a conversation. That type of exercise uses lots of fat oxidation. So that intensity of the exercise is one of the big drivers for how much fat you might partially oxidize during exercise. Another component of exercise that really affects how much fat you burn during that bout of exercise is your fitness level. So a more fit individual, let's say someone who's really been training hard for a marathon, will flip over and burn fat faster than a less fit individual who would burn more glucose for a longer period of time. So more fitness is more fat oxidative in exercise physiology. And then just the makeup of your muscles. Some muscle fibers burn more glucose, some muscle fibers burn more fat. And so even the concept of the makeup of our muscles could affect how much fat oxidation we do with various types of exercise. So the physiology of acylcarnitine production during exercise is a more complicated picture than after fasting. So one of the things we looked at was the correlation. So we took the level of the free fatty acids in the blood sample and compared that to the sum of the acylcarnitines, and we see this positive correlation. So as the free fatty acids are going up in blood, the acylcarnitines are going up in blood. Now this is a relationship between the two and doesn't prove cause and effect, but what we know in general physiology, it suggests that this mobilization of fats from our adipose tissue during fasting is driving or pushing the rise in acylcarnitines with fasting from partial fat oxidation in the liver. But we don't see the same correlation with exercise. So if you compare the blood free fatty acids to the sum of the acylcarnitines, there's no significant relationship between the two after exercise. So again, the complications of exercise is the physiology is much more complicated. So the rise in acylcarnitines could be driven by the intensity of the exercise. Now we held that constant in this particular study. Everybody did a moderate intensity. By the fitness of participants, by the amount of fat stored in their muscle cells that are used that we don't see in the free fatty acid blood sample. So there's a lot of other complications that make it difficult to say what exactly is driving the rise in acylcarnitines with exercise. And it also comes probably from other tissues other than just the liver. So muscles is contributing to this rise as well. So is there a correlation, another blood marker that we could look at that has a similar idea as this constant changing throughout the day of acylcarnitines? I immediately thought of blood glucose. So I looked at blood glucose in these same samples. And blood glucose is a little bit the opposite. It's the yin and yang of acylcarnitines. After an overnight fast, we've been using our glucose store. So when you wake up in the morning, your fasting glucose is the lowest it's probably going to be during the day. So it's lower with fasting. We eat a meal that contains carbohydrate and the glucose will go up a little bit. And then it'll go down again with fasting, and it actually falls a little bit with exercise. So it sort of has an opposite pattern of acylcarnitines. It's lowest with fasting and decreases with exercise, whereas the acylcarnitines increase with fasting and exercise. But just to illustrate that we have these metabolites in our blood that are changing throughout the day, I'll just show you the graphs side by side of the sum of the long chain acylcarnitines compared to glucose. And I think what this illustrates is that our energy substrates are really predominantly glucose and fat. And when we're burning lots of glucose, we're burning less fat. And when we're burning more fat, we're burning less glucose. And so they have this yin and yang relationship of overall utilization to make the energy that our bodies need to function. So again, the acylcarnitines go up with fasting, decrease with eating, and then go up with exercise, and vice versa for glucose. So what about diet? I am a trained dietitian, and I would love to say that diet plays a huge role in the acylcarnitines. We did a study a long time ago where we looked at 3-day diet records, and then the following morning after an overnight fast, we measured acylcarnitines, and this is in 11 subjects with LCHAD deficiency. And we saw that as the fat intake on the upper graph is long chain fat intake as a percent of calories, as it increased, the hydroxyacylcarnitines went up. And as the percent of calories of MCT increased, the hydroxyacylcarnitines went down. So just right before, the 3 days before we compared that fasting blood, there seems to be a relationship that diet may play a role in fasting blood samples. So this is the sample that's really driven by those free fatty acids released from adipose in the liver. What about other studies that have looked at diet? There's been 2 studies I want to highlight. One, they took a patient with VLCAD deficiency and they fed that patient sunflower oil, and they measured acylcarnitines 3 hours later. And the bars in fasting are the hatched bars on the left-hand graph, and then 3 hours after a oral load of sunflower oil, the acylcarnitines are in the black bars, and you can see that 18-1 went up some, but it didn't go up a huge amount. So the amount of diet, the effective diet was somewhat small. It raised it a little bit, but not a ton. And some of them, it didn't change the acylcarnitine species at all. A group out of the UK, Anita McDonald, looked at changing patients with fatty acid oxidation disorders from a very low fat infant formula to a slightly higher one. So going from 4.7% long chain fat to 7.5% in an infant's young children's diet. And they did not see an increase in acylcarnitine. So small changes in the fat content of 3% more from long chain fat did not alter the acylcarnitines in blood. So I'd love to say that diet plays a huge role, and I think there is a role for diet, and eating a high-fat diet we know will increase acylcarnitines. But I also think that the evidence supports that it's the free fatty acids coming from our adipose tissue during fasting that may be the primary driver, especially in fasting. And that exercise is complicated, and it plays a role from fitness and muscle stores and other aspects of exercise that contribute to this rise. So really that brings us to the probably most important question is, are high acylcarnitines harmful? Is there evidence that we have high acylcarnitines that leads to poor health outcomes in patients with fatty acid oxidation disorders? We don't have that evidence for CPT2 or VLCAD deficiency. So we know that with good diet, eating frequently, not fasting, controlling all those things, we can make those acylcarnitines get lower. But having lower acylcarnitines does not prevent metabolic decompensation. We haven't been able to show that it prevents rhabdomyolysis or cardiomyopathy or any of the other complications. Does that mean that they aren't related? I don't want to say that because I don't think we've done the right studies. I think we need to do a larger study for a longer period of time, and maybe we will find that these biomarkers are in fact related to health outcomes if we do a larger study. But at the moment, I can't say that normalizing acylcarnitines in CPT2 or VLCAD actually impacts health outcomes. We did do a study that showed that decreasing hydroxyacylcarnitine slows the progression of retinopathy in patients with LCHAD deficiency. So in this graph was a study we did quite a while ago. We looked at 14 patients with LCHAD deficiency over 5 years. And we measured their fasting acylcarnitines every year for 5 years. And if you looked at the sum of all the hydroxys over those 5 years, low hydroxyacylcarnitines was associated with a higher Rmax, which is the maximal response of the retina, so better retinal response, and high hydroxyacylcarnitines was associated with lower retinal response. So there seems to be a relationship, again, doesn't prove cause and effect, but there's a relationship that high hydroxyacylcarnitines are associated with increased vision loss, specifically in LCHAD deficiency. And right now, that's the best evidence we have that these biomarkers have a potential harmful effect or health outcome. So just let me kind of summarize and try to bring it back home to what do you do with this information. So I think after spending all this time really thinking about what tissues make acylcarnitines, what causes them to go up, what causes them to go down, I can say acylcarnitines vary throughout the day. They go up with fasting, they go down after you eat, they go up if you exercise. Certainly fasting and exercise are big drivers for increased fat oxidation and increased acylcarnitines. We know that if you get sick and have metabolic decompensation, those acylcarnitines go up. So what do you do with this information? I I think one of the things that is really important for you to understand is if your physician is ordering a blood draw to do an acylcarnitine analysis, that you need to think about when you're going to go get that blood sample drawn. It matters if you do it 1 year right after you eat, then they'll probably be low. And if you do it the next year after you're fasting, they're going to be high. And you really can't compare those two because the physiologic conditions in which that blood was drawn it makes the interpretation of that impossible to interpret. So if you're having blood drawn, being consistent about when you last ate and when you get your blood drawn, or when you exercise and when you're having your blood drawn is really important to be able to interpret it over time. And the use of acylcarnitine profiles and routine management is probably not warranted, would be an extreme look. It is nice to have an acylcarnitine when you're healthy so that when you're sick, you can see how much they've gone up, but how useful they are on a day-to-day basis is certainly up for debate amongst scientists. So thank you for going along with me with my journey and my thought process in acylcarnitines. It's been a lot of fun to kind of think through this physiology with all of you, and I am happy to try to address any questions you might have.
Thank you so much, Dr. Gillingham. That was a lot of really, really wonderful information. So we've got a ton of questions that have come in, so we'll try to get through these all as quickly as we possibly can. First question, have there been any reported differences between the brand name Carnitor versus the genetic prescription version?
The brand name Carnitor versus a prescription version of carnitine. I think Dr. Buckley addressed that a little bit. So I don't know specifically about Carnitor versus the prescription kind, but I do think prescription kind has those checks and balances, and you know it's all carnitine. Dr. Harding and I did do a study where I just went to GNC and I bought some carnitine and I shot it on a GC just to measure how much carnitine was in there. And what's on the label of generic forms is not always what's in the actual supplement when you put it onto a scientific machine to measure it. So I think the prescription is the better one because you know you're getting what you think is in the bottle.
Right. Okay, great. Thank you for that. Does carnitine also come from poultry or just red meat?
There is some in poultry. It's higher in red meat, but there is some in poultry. There's a little bit in fish. It's a little bit lower in fish and in pork. There's even a little bit in some dairy products, but there is some definitely in poultry and dairy products too.
Okay, and this might be a question better suited for the person asking's physician, but the question is, some people have the experience of carnitine supplement causing increased muscle pain. What is this attributed to, and should you continue to take the if your carnitine levels are low?
So this is a debate issue, and I don't know that I have a solid answer, but if the carnitine is causing muscle pain, I would definitely go see your biochemical geneticist and talk to your physician about it. However, what's the problem with low free carnitine? We know that really, really low free carnitine is associated with sudden heart arrhythmias. And so we don't want low free carnitine because the carnitine has been associated with low arrhythmic events in the heart. So we want to keep the carnitine. I get nervous if it's less than 10, and we in our clinic tend to supplement if it gets too low for that reason.
Okay. Is there a general interpretation of low plasma carnitine, low urine-free carnitine, and high urine ACL carnitine?
Is there a general good interpretation? No, I think it probably varies from clinic to clinic. Again, I think most labs will use less than 20 as being a critical value and low. And I see lots of patients with long chain FAOs that have 20 or less. If it gets below 10, I get nervous and we tend to supplement. Other clinics might supplement if it's below 20. 30 is often considered, and above is often considered the normal range. I don't know about the urine ones and how well we pick them up. They're hard to measure. The acylcarnitines, especially the long ones, are hard to measure in urine, so I don't know how well we pick those up.
Okay, great. Thank you for that. Do acylcarnitine levels correlate with disease activity or symptoms?
Excellent question. So if you have more sufficient, more severe genetic mutation, or your acylcarnitine's high, yes, I think they do correlate. However, there's all these other factors in play. So if I just take one acylcarnitine measure, fasting measure, can I predict that that patient's going to have severe disease or mild disease? It's probably not exactly that direct. But yes, they do correlate to mutations.
Okay. Do you have a recommendation on how often acylcarnitine should be monitored?
Great question. So that was the reason for this whole debate when we were working on the guidelines. Some clinics don't monitor them, and other clinics, they measure them once a year when you go to see your physician. Again, I think the question is going to continue to be debated, so I hate to give a specific recommendation. If it's just a blood sample taken willy-nilly, it really is difficult to interpret, if not impossible. And you can't just say, I drew this blood sample and that's necessarily related to what you ate. So I think that's the take-home message.
Okay, great. Can you talk about how natural levels of acylcarnitine and carnitine change as we age? Do natural levels decrease as we enter later adult senior years?
Good question. Do I know that? I would need to do a little research to find out how much they change with aging. I haven't necessarily looked at the aging population. Does free carnitine decrease? There's a lot of information about acylcarnitines right now. They're a hot topic in insulin resistance and diabetes. So people with type 2 diabetes see a slight increase in acylcarnitines. It's a blip compared to what we see in fatty acid oxidation disorders, but it's a topic in a variety of different diseases, diabetes being one of them. So if you become diabetic as you age, then yes, your acylcarnitines go up.
Okay, great. Do seizure drugs reduce free and total carnitine? There been any studies on that?
Great. Yes. Seizure drugs. I don't know about the seizure drugs in general, but I had a master's student and we specifically looked at carnitine pre and post ketogenic diet. So if you switch over to a ketogenic diet and a seizure disorder, not a diet recommended for FAOs at all, but a very high fat diet, your carnitine goes down. So if you do a lot of fat oxidation, your free carnitine drops. So you do see lower levels if you make that switch to a ketogenic diet. I'm not exactly sure how much the seizure medicines drop the free carnitine. It's certainly not as dramatic.
Okay.
A drop.
Thank you for that. Are there any studies showing better or worse fatty oxidation depending on the specific gene mutation?
The only two studies that I know for sure related to acylcarnitines is the data that I showed you that I just showed you comparing LCHAD to TFP. And then we published a previous paper that showed something similar. The problem with the data in VLCAD, so the 8 patients in VLCAD, they all had different mutations. So it's really hard to look at them because you can't really group them all. They're all unique. In CPT2, there are some common mutations, and I should go back and look at that. But there haven't been a ton of studies that have really correlated the mutations of the acylcarnitines. And we need to do better at trying to do that.
Okay, wonderful. Do you have recommendations on certain types of exercise that are better or worse for a person with fatty acid oxidation disorder in order to exercise safely without going into compensation?
Right. That is such a great question. I have some ideas, and right now they're somewhat hypothetical, but I think exercise is really important. So when you do exercise, you stimulate more mitochondria. And I really feel like trying to do as much exercise as you can without sending yourself into rhabdo is that fine, tight rope walk that all patients with FAO disorders walk. I've been thinking about high intensity interval training, where it's really, you hit it hard for 2 minutes and then you rest. Hit it hard for 2 or 3 minutes and then rest. There's some interesting data in the exercise physiology world about HIIT. And I wonder if that, I haven't done the study yet, but I really would like to. I wonder if that might be a better approach to exercise for FAO. I would caution anyone who wanted to try that to start very slow, very carefully. Be sure and take breaks and rest. I also think that muscle alternating aerobic with some strength building exercise would be beneficial as well. But again, take it really slow. Listen to your body. If you're starting to feel weak or tired, stop, rest. drink some fluids, just be really careful. It's a tightrope, but I do think exercise is very beneficial.
Wonderful. Okay, and we'll do one last question. And I apologize to everybody. There have been a significant number of questions. So I'm trying to just cover all the topics as best we can. Can you be diagnosed based on ACL carnitine profile and carnitine total and free alone?
You suspect it with acylcarnitines, but I don't know that you can diagnose it. I don't know that any physician would say, yes, that's a diagnostic test. I think that if you see a C14-1 or C18-1 that's really, really high, then you have a very strong suspicion that, yes, it's VLCAT, it's CPT2. But the confirmatory diagnostic test is the genetics to actually find the mutation.
Perfect.
So people don't necessarily do it on acylcarnitines alone.
Okay. Dr. Gillingham, I can't thank you enough for sharing. This has been an incredible session with lots of really, really great information. I would encourage everybody, Dr. Gillingham will also be presenting again tomorrow with Dr. Vockley, so two of the greatest minds together. So I encourage you to join them for that session as well. If you asked very specific questions about your child's condition, I would also recommend that you join the 4 o'clock session. I'm sorry, that's wrong. Tomorrow at noon, Dr. Vockley will be doing another Q&A. And so it's kind of a roundtable discussion, and it'll be a time for you to ask some more specific questions. So I would encourage you, if your question didn't get answered here, to visit with Dr. Vockley during that session tomorrow, and then also join Dr. Gillingham and Dr. Vockley tomorrow for their joint session. So we're going to sign off. The next session will be talking about transitioning from pediatrics to young adult. And we have a clinician there to discuss. And then we'll also have a panel of young adults who are going to share what life's really been like for them and what they want everyone to know. So thank you again, Dr. Vockley. We're going to sign off, and we'll see everybody in the next session. Thanks so much.
Thank you.